So this is a multi-part comment that is going to require multiple layers of response. And the first piece of this is the concern about starting IVs while driving down the road, and risk of needle stick to themselves or the coworkers. And this really revolves around our talk on stroke and the emphasis on
getting them quickly to where they need to be.
Getting them moving, right? So, I guess my first kind of rebuke to this and first layer of discussion is, if your vehicle is, even if your vehicle is not engineered all that well, I know you'll want to talk about design and setup of the truck a little bit, but even with the stuff you have, you can mitigate risk, right? And you should be thinking through as part of your routine how to mitigate said risk, right? So even if your truck is set up poorly and your sharps container is on the other side, there's nothing that says that I can't remove that sharps container or take the portable sharps container out of my jump kit or something, bring that close to me. So, as soon as I'm done with my venipuncture, can go straight in the sharps container, or whatever the case may be, right? Maybe that is you're left or right-handed. Don't start an IV cross-handed if you've got a seat on both sides of the truck, right? Yeah. If you're so blessed, right? But you want to talk a little bit about vehicle setup? I mean, I
think a lot of this is
this can be baked into engineered controls, right?
I think so. I think you can. I think we all essentially, like we talked about, you get a routine.
Right.
You have a routine for what you're going to do. We use trauma patients as a prime example, just because I'm thinking decreased scene time. Stroke, I'm thinking the same thing. You go in the house, you figure out they're having a stroke. We get them to the ambulance. In my head, I'm like, what do I need to do before I leave? What do I need right now? And I might look and be like, oh, they have great veins. I'm good. I will get my IV set up. I'll set it next to me. If I need to move the sharps, we have little ones that go in our jump bag. Those usually end up by us. Yeah. But our ambulance design is the sharps at the end of the bench seat, so I don't need to move one. But we also have a seat on the other side of the patient. So let's say the stroke affected their left side. I'm going to sit on the right side. And my monitor's right there. I can just set my IV setup right there. And, usually I'll move two, actually, so I don't have to get up again, just as a safety measure. Sure. I might not need it, but it's there. So I think if you prep, you get ready, you can start your IV. Our catheters are designed when you pull them out, the end automatically has a protect. It does that, and it goes right into the sharps container. So, I think there's safety measures, design, and if you're anticipating, what do I need to do? If you just take that extra maybe 30 seconds to maybe gather those items, even if your ambulance was not, custom built for what you really wanted, I think you can get it close enough to what you need, and you don't have to get up again in a moving ambulance to try to get something or try to lean across the patient. And I don't recommend using your non-dominant hand. If you start IVs with your right hand and you're right-handed, then start it with your right hand. That's just me. I'm not going to try with my left. It's just not going to happen for me. I know that would increase my risk. I know that could increase my risk for failure. I'm just not going to try it. So I think it's just kind of going through your routine, setting your truck up the way it needs to be, and laying the groundwork for you jet to the hospital.
I can play devil's advocate here and say that there are safer practices than starting IVs en route. I think I can just as safely do that en route if I'm set up for success. Mm-hmm. But again, nowhere do I see us suggesting that you have to do that. It's just maybe time is brain in most cases, time is heart, time is a lot of things. Getting them ultimately where they need to be is what we want. However, nobody says I can't call up front and say, hey, pull over for just a minute.
Yeah,
just give me a second, get this IV, okay, let's go. Or in our case, a lot of times we've got generally 3 guys responding to the incident. We all take a role. We work together as a shift. We take a role, and one of us gets an IV, one of us gets the monitor, one of us does this, and then we go. So, if you don't have that luxury either, there are departments out there that you don't. You have a driver and you, if you're lucky, right? So I can play devil's advocate here. I can say that. But again, I don't think we're condoning anybody saying that you have to do this. No. Pull off, stop, get what you need to do, and go, especially if it's what the patient needs.
100%. And I'm not saying you have to start it en route. So
right.
Please don't take me that way either. that's what I'm comfortable with. I do that a lot of the times just because it's probably about a 15, depending on weather, 15 to 20-minute ride to our closest stroke center. So, in my head, we do the same thing. We only run 2-person ambulances, but it kind of goes back to, when you walk up and you're like, hey, tell me your name. My name's John. And I start going through my assessment. My partner is already saying, I'm going to take a blood pressure and I'm going to do it on that arm. Yep. One person's talking. I'm getting the history. It's kind of like your thing. It's, all right, they already know I want a 12 lead. It's, do you want to do it in the house or do you want to do it in the truck? House or truck? You say one word and they instantly are on the same page as you. So I think you work together and it just compresses your scene time. So if you want to start the IV before you dart, that's totally fine. I've done that on a trauma patient. No, you're going to wait another minute. I'm going to start my IV. I'm going to secure it. All right, let's go. Or I'm going to get those lung sounds. Or maybe I want a couple of things and then go. Or you have the option to pull over, like you said.
Yeah,
pull over
and I would
stop
say
for a
80%
minute.
of the time we're not chasing calls. So it's just the 2 medics on the squad, and half the time the guys are so quick on seeing. I hear them call on seeing, and I hear them calling her out to the hospital. It's like, dang, you guys are good.
Yeah,
they're still getting IVs, and we have a 4-minute transport generally. So they're getting an IV, they're getting a 12 lead, they're getting stroke assessments all in this 4 minutes, and it's like that's knowing your craft, I guess.
I think so. I think it's just building on it, getting a routine. And getting it down, and also working with your partner that you have too. It's kind of like the unspoken rule. You walk in, I know it's my trip. I'm going to do the talking. Scott's not. John's my patient, but he's already getting a blood pressure. I don't have to be like, Scott, could you get a blood pressure? Scott, we're going to do a 12. That doesn't happen. It's just known to do it. So I think as long as you have that good partnership, it's going to compress that.
But a lot of what we keep talking about is
everything
partnership, and a lot of times people don't have that routine. So especially in the volunteer world, and I'm not knocking them, I'm just saying you might not know who you're getting as a shift every time you're there.
That's it. Yeah.
So
But then have that conversation before
You
shift.
have to. You have to.
And it goes back to
Somebody out there is like already typing that. It's just like, I don't get the same person every day. What.
No, so but
That
like you just said, and I think we talked about this a little while ago, is this is at the beginning of shift. This is if I'm the senior medic or if I'm the guy in charge, this is my responsibility not only to make sure that my truck is there and equipped and everything's working, but also to know my partner. And say, this is my expectations of you, what is yours of mine, and
100%.
And I think that's part of us.
And for your volunteer organization thing, I'm pro volunteer as well. I started as a volunteer. I think that relates to training. Bring this up in training. Maybe that Monday night training instead of if it's crappy weather outside and it's
pumping
snowing
for a week. And I'm not saying you don't need to.
No,
but
I think it's very important.
Let's bring EMS back in the house. And the arguments we get a lot of the
100%.
times is, well, that's 90% of what we do. So shouldn't that be more of what we train on? I mean, I'm not saying that fire doesn't put a huge part in this because we need to be training that. Probably more so because we don't go to them.
Correct, we do it less.
But at the same time, we are a constant dynamic situation where we're learning EMS. We need to keep on top of it.
But that's how you touch those people that you don't get the same consistent partner. So in that volunteer setting, that training night, it might be 2 hours of how about you do some scenarios? How about, if we're all on the department and, Scott and I are the crew and John's our patient.
Right?
All right, you play the patient and maybe you're like, hey, this is your patient. This is John. He can't talk to you. He's having a stroke or whatever. You play his family member, and we go through it, and you work together. And you could do the 12 leads. You could work on all these team dynamics, essentially, for a lack of a better word, to improve it. So I think training is where that comes into play, and that trains everybody and says this is the way we're going to do it.
We have to operate as at least two. So you have to be part of the team. And what we were talking about earlier when I said, the basic is just as important as a paramedic.
100%.
Because they're the ones that are going to sit back and tell me, hey, idiot, he hasn't been breathing. And I'm going to say, you're right, my face has been in this monitor.
Hey, Ray, look, rhythm change.
Yeah.
It's doing something else.
VTAC.
Yeah, so, I mean, it's...
Yeah, I think that just comes down to teamwork, team building, your training program in your organization, and I don't care if you're volunteer, part-time, or full-time. I think we could all do the same thing 100% of the time, deliver
Look, there's quotes out there
care.
that say volunteer, full-time, IAFF, not IAFF. It doesn't matter. The fires are just as hot when we get them.
Care is
the
quality
EMS
care.
is just as real when we get them.
And it boils down, in my opinion, to training.
quite
Well, what
honest.
we can do too is if Ray and I walk in and I'm medic and he's the basic, I can say, "Oh, hi, ma'am. I'm
He's
John."
always got to
I'm
be
a-
in charge.
Yeah, I'm the doctor.
There's a reason I'm a
He's the
doctor.
paramedic, I'm the doctor.
I feel like
Follow
Dr.
your
Gray.
protocol there.
You're gonna talk to me. he's just here. Okay.
But I can say, like, based upon what the call is, I can say, oh hi ma'am, I'm John, I'm a paramedic. We're gonna do an EKG, we're gonna get a blood sugar on you, and we're gonna start an IV, and I can tell her, the patient, that's what we're doing.
Knowing that I'm telling my partners the same
I'm telling
thing.
everyone in the
You're
room,
loading
This
that.
is our, yeah.
100%.
This is what the plan is. This is what we're gonna do. If I don't know what it is until I walk in and be like, this is what we're gonna do, and everyone in the room knows what's happening.
And it speeds it up, lets them know versus like, oh, what are you putting on my arm?
Yep.
You know, it stops the whole.
Oh, Ray's
what's
gonna
this?
Ray's gonna
You know,
do
it avoids a lot of that.
Yep.
Exactly. Yeah.
And I'm fortunate enough, I think every shift I'm working with the same guys. And we know for a fact that if we get a full arrest, I'm going to take the airway because I'm an ass like that. And then somebody, the same guy's going to take the meds, the same guy's going to take the monitor, and we work very fluently together.
Yeah.
And it all just works out. But again, not everybody has that luxury. So it's part of our jobs to make sure that we make it our luxury.
Absolutely.
Or I'll even take it one step further. On the way to the call, no different than a fire. Obviously, everybody has their job, and I'm very pro that. But talk. You have that response time to say, hey, this is a stroke. This is what I'm thinking. What are you thinking? Have that conversation on the way there. Like we talked about peds earlier, where our dispatch gives you the weight. Okay, if this is a ped seizure, I'm gonna give the drug box. I'm gonna give Versed, and I already know the dose.
Or
It's based on the weight. Like,
if
you know what I
you're-
mean? I'm thinking down the tree already here, so we have that conversation. Do a little pre-plan there. It's not
Do the pre-plan while you're driving, and if you're the basic, ask those questions. Like,
100%.
hey, Ray, what do you want me to bring in? Do you want the jump bag? Do you want this bag? Do
Yeah.
you want me to bring cotton?
Well, if I
What do you
recall,
want?
one of the questions that are probably going to come up here in a minute too is about 12 leads and during transport and artifact. And again, if you have a competent basic, nobody says the basic can't do the 12 lead for you. They just can't interpret it.
Yep.
So there's that. Also, one of my biggest pet peeves is that people say, we can't be moving during a 12 lead. What happens at a stress test? They do proper skin prep. I'm running on a treadmill and they're doing a 12 lead and it's crystal clear. So one of my big pet peeves is we're not doing proper skin prep. And if we are, there's still 60 hertz interference with your inverters and such, but
That's
we can turn it off.
done. It's over with.
So I don't know. I don't like that
Or
argument.
take the monitor in the house. Here.
How about
Let me-
just take them on in the house?
Let me throw something else out.
Which, if
I
it's
called
cardiac,
for
it should
chest
be
pain,
anyways.
and I'm pro that. If you call for something like unresponsive or chest pain or whatever, I like the monitor going in the house. That's me. That doesn't have to be your procedure at your place. Everybody does it differently. I like that. If you call for chest pain, I want the 12 lead right out of the rip, because if they're like, I want to go to this hospital that's a non-PCI center, I can squash that right now and be like, I'm sorry, we need to take you here because I have 3 or 4 options out my way, and only 50% of them are PCI. So I can have that conversation really quick and say, hey, I want to take you here, and this is why. Do you understand? Does family agree? And then the family knows where they're going. And I instantly know in the first couple minutes, I'm going to get my EKG in less than 10 minutes.
Yeah,
So,
and I mean,
I
even
like
full
that
arrests,
way.
even,
may
I
also
mean,
be mandated in protocol.
Yeah, it's in the protocol.
Door to EKG is less than 10 minutes.
So I think it's easier to take it in there. I don't get interference. I don't have to worry about it. My partner knows it. And back to your skin prep, Tim Phelan, we've all heard him speak.
Yeah.
UH has had him out for
Numerous
multiple
times, yep.
multiple symposiums.
Excellent.
And
If you
what's he
haven't been
talk
to one.
about? Wipe off the oil from the skin. Flip over the back of the EKG
Did you know
electrode.
they have abrasions on them?
Yeah, so you can just kind of scuff up the epidermis. Then you actually apply the sticker. You get good skin contact then. Or some EKG stickers or electrodes are not as good as the other ones. You need to spend some money. I'm sorry. I'm a firm believer in that. We do that in our organization. We buy the same ones pretty much they use for stress tests. They stick better. They give you a better picture. Yeah, it might cost a couple dollars more, but I'm going to get a better performance out of it. So,
and you're not going to use 10 extra.
Exactly.
Peeling them off.
Yeah, because they peel off, you throw them away, you peel them off. So
Yeah. Or
you're really
they're
not saving
dry,
money.
you're throwing a whole package away. Absolutely. Right.
Placement's key. Placement's absolutely key. I mean, we have razors. Use them if you're smuggling Chewbacca under your sweater.
So it reminds me of the CPR video, the AHA. If you have a
When they
extremely
take the pads,
hairy
and that guy
patient,
really
you put
did
the
that
first
too.
pads on, and then you wax them, and
Did you
then
see
use
how
the
red
next
his
set.
skin got after they pulled him off?
Yeah.
Oof.
Oh. Painful. All right, what else do we have as part of this? So I think we covered the 12 lead.
So yeah, so and that question, if they hadn't deduced it, was or the premise here was that you can't get a good 12 lead in a moving vehicle, and we just talked about all that. There's methodology to avoid that, and
Or pull over real quick and run it. I think
Like the
somebody said
IV, if you want to,
just like that IV, right? Yeah. You can, if you really have to move, you can put all the stuff on as you're going, and then all right, call for a stop, right?
Yeah.
We were talking offline about I had a case similar to that where it was a post-arrest patient, and the monitor started going haywire, and I wasn't quite sure if the patient was trying to die or not. The patient didn't look like it. I'm assessing that, trying to troubleshoot, what's really going on. Like, stop the truck for a second. We got to figure this out. And it turns out it was just motion artifact that was on the blood pressure side of things that was giving me all kinds of wonkus results. Nope. Okay, we're good. I could see the hospital. Through the front of the truck. I was like, no, but if I need to resuscitate this patient, I need to do it now. I'm not going to hurry up, drive down there, and then be doing compressions in their parking lot if we can avoid that, right? And then, although I wholeheartedly agree that taking a cardiac monitor into somebody's home minimizes the chance for 60 cycle because you're not nearly as close. I have had situations, specifically at nursing homes, where patients with air mattresses with the compressor at the end, or DVT prophylaxis machines or anything like that, throwing them on there, and then you get a bunch of 60 cycle. And that's simple fix, right?
Yeah.
You can either unplug the things or just move the cardiac monitor on the floor, move it away, and just like that. So the next piece of this is doing a van assessment en route, and am I going to be able to do a van assessment en route?
I don't see why not.
This is an issue. Yes.
Yes.
Yeah, I think so. I mean, you do the Cincinnati in the house, maybe get your blood sugar, decrease scene time, get them in the back of the bus. I can do, you start with arm drift. That's the first test.
Unless the question is more in line to
you keep
doing
going.
IV 12 lead and van before I get there, which in that case I would still say yes, unless you have like a 3-minute transport.
Well, there's always going to be that case.
Absolutely.
Yeah.
Right.
I think
Absolutely.
you get as much done as you can.
I don't think we delay transport to get a van assessment, though, if that's what the question is. If we're en route to the hospital, I'm not going to pull over again for the van. I may need an IV. I may need to get my 12 lead because I do. But the van is more or less, we did our Sensi, right? And that's going to...
Yeah, because we teach Sensi in the house, van during transport.
Yeah, and if we did the Sensi, it's going to tell us whether or not we're doing the van. And if we do the van, I wouldn't delay that transport at that point to get a van. Like I'm going to try, but
Sure.
not.
But yeah, your situation is your hypothetical situation is you're 3 minutes from the hospital. What's important here? Well, you already failed the Sensi because we're here, right?
Right. So
I can already call a stroke alert
You
based
can
on
call
that.
a stroke.
And we know the hospital is going to repeat that. It's going to be the ER physician
because
that
we're going to
repeats it.
trend our vitals. We're going to
trending.
trending our findings.
And if I gave you a positive van with left-sided deficits, you're going to look for them to be worse or better.
Correct.
So I don't think that. Again, I just love that trending factor of things. There's a reason we do that.
Well, and what do you guys think about this? Of those things, and you're using this time compressed model, right?
Your priority list.
What would my priority list be, right? And
A Sensi in the house, a blood glucose,
a Sensi and glucose
An
I think
IV.
are non-optional.
because I want a CT if it is, and he can do it with my 20 at least in an ampicule or above. And
You're
then,
saying IV then 12 lead? Because my mind goes 12 lead then IV.
I guess for stroke.
I want to know if there's more clots.
I want to do a 12 lead.
Yeah, I guess you're right. Yeah.
Yeah, because the first CT is going to be a non-contrast, and then if they're van positive, and depending on the time frame, they'll follow up with a CTA.
Well, and if you guys, if I don't get a reported van, if they're van positive, I'm going to do with the extra stuff that I need to do from my standpoint. But if you guys don't report that, I'm going to do it anyways as we're walking the CAT scan. I'm assessing the patient. I'm making sure I don't need to go to a room to get an airway. If their airway is intact and I think that they can go to CAT scan safely, we're going to go to CAT scan. And I walk during them, I'm going to do my assessment. I can do a van at that point. I can do a whole. I typically don't get a whole NIH stroke scale done during that walk. I can get the majority of it. But I mean, what's van, right? Vision,
acuity, and neglect. It's pretty easy.
Yeah.
Vision, aphasia, neglect, yeah.
Yep.
I mean, you start with arm drift, so I think we could prioritize it as, you go in the house, you get your set of vitals, your glucose, you do your Cincy, they're positive, I put them on the cot. I think
I guess
I
I'm always
personally
thinking
would
of
do the
doing 12
12
leads in the house. So I'm not thinking
or we
of
could
it in
do,
the
we
route,
do 12 leads in the house a lot too. If you call for a stroke, I'd say it'd be 50-50 depending on the cruise. So I would say get the 12 lead and then we jet, and I would work on the IV in the van and route. Because at least I know if I think this is a stroke, I've already ruled out hypoglycemia, I have positive Cincy findings, I have enough to call and say I have a stroke alert, right? Because there's going to be no financial impact to that patient at all. They're going to prioritize a CT scan for them. That gives a heads up to the physician. It clears the table. So essentially, that laid that groundwork. Yeah, I don't know. That's just the way I think. At least I know the groundwork's laid in the future. I'm doing what's best for the patient, and
I don't know.
I still
It's
think
a
you
very
could start the
personal
van.
thing for me. My mom had a massive hemorrhagic stroke. It's been almost 4 years ago now, but the squad did a bang-up job. They did great, and they got him to the hospital. The hospital, they got her ultimately to where she needed to be. But if they had delayed their care any further, she probably wouldn't have been here. So to me, it's a very personal thing. You can get these things done because the squad that brought her in, it was Chardon, had like a 4-minute drive to the hospital and got all of this plus done before they even got to the hospital.
I think it goes back down to teamwork. I don't know. Maybe I keep picking that up the wrong way. I think it goes back to teamwork. Your crew. Everybody needs to pitch in and do what they need to help the patient at that time. And an EMT can do a lot in this nature. They could be the one that gets your blood sugar. They could be the one that's doing the 12.
Yeah. They can do the van assessment.
They could do that.
I don't need to do that.
We could work together, So
Right.
it's just, I don't know. I think it goes back to practice, train.
I think one of the biggest
Teamwork.
problems is that most of the time we're like this anymore. And you got plenty of time to do that later. Put the iPad
Put the
down.
iPad down.
There's a human
Treat
on the
your
other side of
patient,
that.
yeah.
100%.
And
I agree.
remember that your monitor is going to import everything that you want to anyways. You have the event button for a reason.
Yeah.
We need to, like we were talking earlier off this, we were talking about some of the first few weeks in class is the best because nobody wants to touch anybody. We're all very anti-touchy, and it's like, that's not us.
Yeah.
If you're not hands-on, if you're not conversing with my patient directly, I'm no good. So put the machines down, do your work.
Get the bread and butter. I mean, you already have the address because you went there, so that's where they live. I need your name, date of birth, social, allergies, history.
That's it. And you
Last
might not
name
have an
well.
alert patient to give it to you.
No. So I mean, I might have limited information
out later.
Or
Let me
it's
work on
really-
the patient now.
Or it's easy to turn to a family member when I'm doing that. Hey, could you write down that patient's first name, last name, social, any allergies? Please write it down. That just took that off of me, and they're going to hand me a piece of
And
paper.
most
All
people
right.
can use easy technology too. My iPad's patient form is so easy. I might be able to hand that to somebody and say, "Can you fill this out for me real quick? Just stay on this page and fill it out."
And then I'm back at my patient again.
And then it's amazing too because you get insurance information and stuff. I don't need any of that.
Which questions haven't we answered?
Well, down here to the van assessment, am I going to be able to do it en route? If the doc can do it walking down the hallway, I'm pretty sure you can do it en route, right?
Yeah, I agree.
And you've done half of it already with a Cincy,
With a
right?
Cincy, correct.
Yes.
Because if you don't have arm drift, you're done.
Yep, the van
And
negative.
then if they have aphasia and they've got arm drift, you're positive. Half it's already done. Neglect is pretty obvious. The only time it takes is visuals, but you get your stuff done, you throw some stuff in front of their eyes, see if they've got any neglect, or ask them, and easy peasy.
I think one thing that's worth saying real quick too is I don't have to do this all at once. If I do your vision and I get to the IV real quick and I come back and do your drifts, I mean, I don't have to do it right down a list. Like, make note of
time
what it
management,
is, and
Yes.
The other bits of this really revolve around seatbelt use in the back of the ambulance and whether an accident may or may not be covered by workers' comp if you are seatbelted or unseatbelted. And this also, I'm kind of ascertaining out of this that that the angle of the question is you can't do certain things from a seated position. So my guttural answer here would, from 15 years ago would have been one thing I probably would have agreed, but I have coached myself to do things seated, and I'm a dork. I actually wear my seatbelt a fair majority. I'm not going to say all the time. I am pretty damn good about wearing my seatbelt in the back of the truck during patient care, and I only unbelt for truly life-saving or, critical situations. Not perfect, obviously, but
I also think that question had something pertaining to Ohio law, and I'm thinking maybe that's ORC they're referring to.
So there is no ORC.
I would love to see it if there is.
OAC that says that we have to be restrained, right? First of all, it's just common sense.
Now maybe that's interdepartmental policy.
Yeah, there it is, right? Policies, of course, are going to be written to keep the provider safe, and they're going to say you should be belted at all times, right? And I think most reasonable providers would. There is probably a small sliver of time that we may need to be unbelted, but again, proper vehicle setup, proper pre-planning, proper routine where stuff's in. Some of that's incumbent upon us, right? And if we got into an accident, and happen to be unbelted, that you're on the job. I mean, even if the policy says you must be belted, you may be in violation of a policy, but there's nothing that would prevent, unless you failed your drug test, there's nothing that would, prevent the workers' comp claim from being processed, right? So I think that misconception is out there. Not that again, I believe that most people should be restrained in the back as much as you can. I didn't do it for the first half of my career.
No, I was not the best at it. But now with ambulance design innovation, they have harnesses that we could wear that move with you.
Yeah, it's getting better.
It's definitely improved a lot. Ambulance design, so that if you sit down, my garbage cans here, trash cans here, a couple drawers of my IV stuff, my oxygen points right here, my monitors right here on a swivel. I don't have a lot of reasons to move.
Correct.
To be quite honest, I should be able to do most of my job from a seated, restrained position.
And if you can't, try to get on the next truck committee and give your input to say this is where I want change.
I think oftentimes I must gets overlapped with I want to, right? Is I've always done it this way. And I'm telling you, like I said, the first half of my career, I wasn't good about it. Restated, I didn't do it. And, in the latter half, after I got tired of getting my head smashed on oxygen regulators and banging into cabinet faces, I'm like, there's a real easy way to fix this, right?
Yeah, I know they had some straps in here to hold me.
Right. And now, was that a paradigm shift in my mind? Did I have to learn some new stuff and do things differently? Absolutely, right? But again, that goes back. We were talking about workflow earlier. Mm-hmm. Now, where my bag used to just get thrown up there because I'm working out of the cabinets, that's not my game anymore. It's tethered next to me, and I basically work out of that unless I need a few of the very specific tools that are on my ambulance that aren't carried in my big blue sack right there, right? I just work right out of that.
Yeah.
And the last piece in here is a little near and dear to me because I'm a big part of writing it. Is how about right protocol to keep in mind? What's more important, time or procedures? That is, I promise you, that is incredibly considered in the way things are written, right? But we can't write a protocol for every single case with every single set of of events, right? So.
And there's also a reason that every year you
have to make
2023 revision 1, revision 2. Revision
always
3.
Getting better.
It's always getting better, and if you have input and thoughts of how we can make it better, talk to Scott.
Talk to
your med directors, talk to EMS coordinators, and those more or less go to the docs and they discuss it, and you guys make it better.
In the protocol, there's an email. And that goes to the entire team for review, right? So if you have questions, comments, concerns regarding protocol, let me restate that. If you have ideas or corrections questions or comments don't belong there, right? But if you have ideas for improvement, or if you have, suggestions,
pieces of
misspellings,
equipment, something.
that email is where to send them, so they get put in the pile for review. First pass by the paramedics, second pass by the docs and the paramedics. Once we've kind of distilled out what what we think we need there,
And that works. I've seen it start to finish work. So
that's usually
the changes are made.
That's usually the first thing we do in the meeting. Is actually we sit down and here's all the emails we got. And let's
here's
go.
the input.
We go one by one, and then we get into everything else. Actually, the emails are the first thing we review.
Generally, yes.
So people that use it, right?
Yeah.
Boots on the ground.
So, all right, you guys have anything else here?
I think that's it.
I think that's it. So, hey, everybody, thanks for joining us today. And if you like the content, follow us on Facebook. Let's subscribe on the YouTubers. The prehospitalparadigm.com is the catch-all for all of this content, plus more free open access medical education from university hospitals. So check out that website, and we'll
Send
talk.
us a question on there.
And actually, we would love more questions like this.
True.
This is fantastic, right? Go into podcast, and one of the options in the podcast drop-down menu there is submit a question, right? We'd love to hear stuff like this, and we'd love to tease it out and argue about it on air for you. Yep. So everybody have a good day. We'll talk to you soon.